going to go over some EKGs. Just kind of a review of the year. It's going to be kind of relaxing, not too stressful, hopefully. And some mix in some board review too. All right, so first EKG. You guys can, I'm not going to pick on anyone individually, hopefully. Just tell me what you think. This patient comes to the with chest pain. Sinus, yeah. Any signs of ischemia?
Like subtle elevation, like B5, B6. So
Is it elevations or PR depression? What's your reference point? I actually can't even see that well here. TP segment, yeah. So maybe there's an elevation, but nothing.
I mean, and those leads to be significant, it should be about 1 millimeter. That's
Yeah.
less than 1 millimeter.
If you were
You can repeat it.
if you were the doc in triage, would you say this patient needs to go and come inside or can wait a little bit outside after some labs? Make them wait. Yeah, no. This is recorded? Yeah, this is a what we call a normal non-specific EKG. This is a reference for all the upcoming EKGs. They're all gonna be abnormal. Our next patient, 54-year-old female, history of ESRD, presenting with melena from weakness, is now sitting in 4 hallway. Can't get labs, just hard stick. This is a real patient. This is a real patient. They gave me this EKG on rounds. CCT had like 30 patients, so I was like, oh, we gotta deal with this here. See, she didn't. So she didn't miss dialysis. Yeah. Does that rule out or rule in? What are the likelihood ratios? So what do you guys think? What's the diagnosis? Hyperkalemia. So some findings. You have like diffuse symmetrical T waves. Borderline wide QRS, and sometimes you can see right axis. So this is hyperkalemia. This patient ended up having pretty high. It was like 9 or something, or 8. She also had a hemoglobin of like 2 or had to activate MTP in the pod. Caused a lot of frenzy and yelling. See, but
Right. Get that comment with
oops. Yeah, it's kind of any like you can see in sodium channel blockade. You can see in like hyperkalemia. I don't know the percentages on it, but it's
Okay, the only other finding for hyperkalemia is that P wave looks like it's starting to flatten and the PR has gotten a little prolonged. Usually start to get that kind of late in hyperkalemia as you start to get the QRS widening. You'll also get the PR and the P wave affected. So that looks like that might be happening here as well.
Yeah, the PR looks a little prolonged, maybe, but it looks flat too. Yeah.
Yeah.
used to be borderline right axis, but it looks positive on one, especially with the wide.
That's a good.
I don't know. If you dig deep, 2 millimeters, 2 millimeters down here. I don't know. This is a stretch.
Yeah.
I was just trying to squeeze in all the findings on one EKG. See. All right. Well, you already saw the answers. This is a 32-year-old presenting with syncope. This is discharge or OBS or admission. You want to OBS this? No. What are some abnormal findings?
Oh, SP elevation, T1, T2.
Yeah. What else? So this is concerning for, I heard already, Brugada. So you have to have the clinical parts of the diagnosis of Brugada syndrome. You can have Brugada EKG. Not every patient with Brugada has Brugada syndrome. All right. Do you guys know how they diagnose it? Yeah, I think you give them a sodium channel blocker and then induces VT. But not every patient with Brugada syndrome it's like a polymorphic, like most of them have sodium channel, but there's other channels that get affected too.
Yeah, the other thing there, besides being suspicious of Brugada, which by the way, on your last in-training exam, which I have the honor of taking, after you take it, there were 2 questions on Brugada. Right, so no Brugada a little bit. The definitive treatment for Brugada really is, especially if there's a history of death in the family at an early age, the true treatment is to put in a prophylactic defibrillator.
So this patient shouldn't go on OBS. I don't think Brugada is an OBS exclusion, but
It's also, can it be the saddleback?
because I think they need an EP study. You're gonna admit them for an EP study, or I don't know, or just discharge them. I don't know. See,
You know, at least get cardiology involved.
it might be OBS on this side of the street. I don't know too much. That one's tough. So I think if you have resources, you probably would consult cardiology. If the patient didn't know. Yeah. Now that I've gone, some years as an attending, you know, you think a little about malpractice. Yeah, I'd probably just get cardiology. If you don't have cardiology, maybe give them a call and say, hey, I got this patient with the Brugada EKG, never syncopized. Can they follow up in clinic? See.
And you can be surprised, even in young people, that's where you're gonna see this. The last case I had of this a few years ago at UAB, and this guy, he was a PhD student doing research, and he was getting his physical exam at employee self-service, and they drew his blood, and he had a syncopal episode. Okay, so we all said vasovagal, right? Did his EKG, and he had a very impressive looking Brugada. Now, not every, as you mentioned, Eric, not every change is Brugada. But then when we asked him closely, he had a brother who died at a young age, unknown cause. So I actually called Dr. Budakowski down, and they arranged to do EPS studies on him.
All right, next patient, 41-year-old, comes in kind of altered with white powder on his face. What's the rhythm here? What are some abnormal findings? So sinus stack, yeah.
Terminal R.
Can you explain what terminal R is in AVR?
Goes down and then it goes up.
Like every other QRS? No. So
It's like a
Yeah. Yeah, kind of. So you have basically you don't typically don't have a tall R wave in AVR. Here it's like, I think that a terminal R, you have to have at least be 0.7 the size of the S wave. So close, 0.5 maybe, but it looks abnormal. It's easy to tell when you know what this clinical scenario is. Anything else? I think you probably some right axis, actual right axis here. What's the diagnosis? What's the diagnosis and treatment here? Yeah, so this is cocaine tox causing sodium channel blockade, and the treatment is bicarb, probably some benzos too. But
Terminal R and AVR, that's specific for sodium channel.
yeah, so that you can see that or you see in TCA. I can't remember if you can see it in just people who take TCAs or in tox. I can't remember actually.
Why is it
Bicarb, bicarb is just very hypertonic, so you're just giving a lot of sodium because it's a sodium channel blocker. You're just gonna overcome the blockade.
Is there anyone who's still on TCA?
Yes.
There are.
Is it like an EMCCM every year? TCA tox? No. Some type of people are still on TCAs.
Yeah, I mean, when you're treating this and you're treating, for example, a tricyclic antidepressant overdose with that widened 2RS and because of alpha blockade, when you're giving your sodium bicarb to treat it, you're actually, what you want to do is make their blood alkalotic. It's not so much their urine, right? So, and the way I always did it is I started with a bolus of sodium bicarb, 1 milliequivalent per kilo, and then I would hang a drip of D5W a liter with 3 amps of bicarb in it, and then run it to get the pH around 7.5 or something, 7.5. When you're doing it for salicylates and phenobarb overdose, you actually are alkalinizing the urine because you want to increase excretion, right? And so it's a different reason why you're doing it, but those are two good reasons to use bicarb. But here you're alkalizing the serum to protect the sodium channel.
Yeah,
from-
I think the QRS widening is actually associated with seizures. You get seizures in TCA talk. So the narrower your QRS, the less likely you'll seize.
The other drug you always have to worry about when you go into these weird rhythms that could kill you, like with torsades or something else that we don't always think of, but high dose methadone can also cause problems like this, can cause torsades and severe arrhythmias.
All right. Speaking of arrhythmias, what's the rhythm here? So in AV dissociation, you'll see your R to R intervals should be the same, right? So look down here.
Like variable AV block on the rhythm scale.
Yeah, let's an AV block. What's the second degree? Is that? I guess there's a variable ratios of the degree of block. I don't remember the exact terminology, but what is this, type 1 or type 2? Type 2, yeah. I think, yeah. So yeah, you have PQRS, P wave, then drop, and then I think down the line you have a couple more QRSs that before a drop. You have fixed PR intervals, second degree AV block, type 2.
This is the more dangerous one compared to
Yes.
the block, right?
Yeah,
Yes.
yeah. This is the one you could probably admit you look for reversible causes and probably will get a pacemaker.
What is 2 to 1 though? Technically, can you tell the difference?
You can't.
You just assume. it's
Yeah,
the person
you-
need to get.
Yeah, you could put them on telly and then they'll sometimes get out of 2 to 1. They'll be like, I don't know, they'll have 3 beats and then you can tell.
Yeah, is that what it did down there?
This one is 3 to 1, right? Or 3 to 2? Yeah, so it's not 2 to 1.
What are those, I see like the normal conducted T wave on the rhythm strip, and then you see the unconducted T wave after the T wave, like in the rhythm for 2, and then you see that other little blip that looks like almost like a smaller P wave, like where that, yeah, what is
That's hard.
this artifact?
Yeah, I think it's not wide enough to be from the sinus. Yeah.
But you see it again, like pretty clearly, like,
Yeah, you
Here.
can sometimes see those.
Yeah. Or say one little ectopic foci.
Like
Yeah.
you get AFib, sometimes you get fooled. You think
Caleb.
it's the extra beats, but that's
Like I did early on, you can't say very like.
Yeah, it's type 2, definitely. You can actually tell here, right? PR. Yeah,
But just to like a 2 to 1, you can't necessarily tell.
yeah. If their QRS is wide, sometimes you can assume. Sometimes a little bit lower down, yeah. But what if they already have a baseline block? So you know, it's hard to. But that's why they have to go on telly. So you don't want to AV block them, right? Because they're already blocked. I think you're thinking flutter or something. Oh, to see what type? That's pretty bold. I probably wouldn't do that. Yeah. Yeah.
I would call it type 2. Number 1 is more
Yeah.
dangerous. You don't want to miss the more dangerous thing, but also the clue to type 2 over type 1, one of the clues is whenever you see a QRS with a type 2, the PR is always the same. Right now here, you don't have a long chance to see that because you're only seeing 2 blocks. But for me, whenever I see that QRS, there's a P in front and I never see a QRS with a different PR. So for me, that's
Time
gonna be a
action.
type 2, which is more dangerous. And I'm gonna treat that as a more dangerous rhythm compared to Modus 1. They're gonna get admitted to the ICU, they're gonna get a cardiology consult.
This is actually a real patient, 65-year-old male, presents with chest pain, now resolved. Now is a sign out to you, and you get this EKG on rounds. What's going on here? It's yeah. What's the rhythm first? Are there P waves before every QRS? What's the rate here about? About 100, and I've heard someone mention a left bundle, but is it really left bundle? Yeah, so you could be right bundle. Someone mentioned left anterior fascicular, so you're down in these inferior leads and up in the high lateral. So you have it's wide, no P waves. Is this regular, irregular? Regulars. So what's the rhythm here? Can it be junctional if it's super wide like this? Yeah. It's what?
If there's like a big
Oh, junctional with a Barency? Sure, that's yeah, reassuring, but we always assume the worst, right? This guy just had chest pain.
P waves looked pretty big in some of these leads as well. Two,
Yeah, they're tall, but you were thinking about hyperkalemia?
no,
Nah.
more like, I guess I was considering like a hyper P, but they don't really look.
Let's go back to the rhythm. So you have a regular wide complex tachycardia at 100. Someone said junctional with a Barency, but that's too advanced for just a simple ER doc. What should we assume this is? This is ventricular tachycardia. This is kind of is this monomorphic VTach? It seems a little slow, right? So I think terminology wise, this is actually something we call accelerated idioventricular rhythm, and it's seen classically on boards and in life after an MI. It's a reperfusion rhythm, something to do with oxygen radicals and stuff, and it's typically it resolves. You provide supportive care. If you try to convert these patients or give amiodarone, or they might go into asystole because this is an escape rhythm. So this patient actually got transferred and had an LAD occlusion.
Where you can sometimes see this, let's say he came in with the chest pain. I think, and Eric is touching on this. He comes in with the chest pain. He has an MI. You don't have available within 90 minutes or to 2 hours, you don't have available a cath lab. You decide to give him TPA or TN kinase or Retivase. And sometimes as they get better from their MI with a thrombolytic, you will see this idioventricular rhythm. And they usually, as long as they're perfusing and they have a good blood pressure and a strong pulse with it, you don't touch it. You just watch them. Usually it goes back to a normal rhythm.
It's not Willems. Nah. This is, you actually have to have basically an MI first, like a STEMI.
What's the distinction between this like accelerated video and like a slow VT?
This is on the spectrum of VT. Slow is, I think, was it like in the under 100 or 70s or 80s, 60s?
Oh.
Yeah. But you just have to look at the question stem or the chief complaint. See. Which one is this one? All right, 67-year-old presents with metastatic or has a history of metastatic cancer. Now with shortness of breath and syncope. Good across this low alternans. So you see varying QRS complex amplitude. Tall, well, small, smaller, small, smaller. Do you guys know the criteria for low amplitude, low QRS? So it's you either have 5 millimeters in the limb leads, this half, or less than 10 millimeters in all leads in the precordial leads. And these are all like, I think, this might be 7, but I think these are all under 10. This is concerning for what? Pericardial effusion. See, what else can cause low amplitude QRS? Big body habitus. So anything that increases the distance from your heart to the electrodes. So that can be body mass, that can be COPD if you're hyperinflated. Anything that messes up your conduction, a lot of it like infiltrated disease, like hypothyroidism, amyloid, you can see that too. But you should, as an ER doctor, you should assume the worst. So go do a POCUS. All right, 56-year-old presents with wheezing and respiratory distress. We're going to focus on the rhythm here. Gar, did you just go by the questions then? Yeah. So what else? What defines what defines multifocal? What are the features? EKG features. Yeah. So you need 3 distinct. How's the rhythm? It's irregular, right? But there are P waves. And then you have to be tachycardic. What it's called, I think, what is it? Wandering atrial pacemaker if you're not tachycardic. What's the treatment? Treat the cause. Yeah, no. Rarely does this cause itself cause the kind of instability, so it shouldn't be really cardioverting these patients. See, but here you can see three distinct P waves, and it's pretty irregular. You guys got that?
Yeah, and often it is COPD, and you can treat them with albuterol and with steroids and MAG. The other thing, some rarely, and maybe due to CHF. And the other thing to consider is giving MAG. So that may help in some studies.
Yeah, and you're gonna give MAG anyways for
Yeah.
COPD, but it's sometimes CHFers can also anyone in respiratory distress. All right, 26-year-old male, history of daily cannabinoid use, presents with vomiting. This is actually sinus tachycardia. This is a normal EKG. Others are. So yeah, QT is definitely long. It's so long that I think the T and P waves are kind of fusing. You can see in V3 actually. What else? Anything else abnormal? About the T waves, ST segments.
Your keyword. Kind of, nah, not really inversions. Kind of. 550.
Yeah. What about what I see here is a diffuse ST depressions and an AVR ST elevation. This guy's got chest pain too, with vomiting. Would you activate CAF on this patient? Dr. G's left. I've seen it done. I don't know. Would you? I wouldn't. I don't know. What would you do? What would you treat? What would you do with this patient?
Lights, probably.
Yeah. So what electrolytes are you guys worried about? What electrolyte derangement?
Hypomag, hypo.
Hypokalemia. Exactly. Yeah. So definitely prolonged QTs. Patient's been vomiting, probably a lot. They're pretty tachycardic. So, just going over the differential AVR isolations. Either a lot of it, sometimes it's ACS. Most times it's not ACS. So just go over your differential hypokalemia, hyperkalemia. Definitely anything that affects your repolarization can cause that pattern. Here, we went over this. There's definitely prolonged QT. There's a TU wave. From what I've read, the T wave is the inversion and the U wave is actually upright. But some people say it's the other way around, but I don't think it matters too much. But you got these biphasic T waves. They're reverse of Wellens, right? They go down and then up. You can see in hypokalemias. And this patient was given, I think the K was pretty low, it's like under 2. And they were repleted and they all better.
But talk about management of CHS. Are you getting EKG electrolyte before you start giving prolonging agents on your test patients?
So that is attending to attending. If this patient was writhing around, getting out of bed, really agitated, I'd probably just give Haldol. There's studies about Haldol on the patients who are at risk for, going to, torsades? And it's usually the patients who have underlying heart disease. So electrolytes alone, maybe not. So you're giving a pretty small dose too. If you're worried, you give 2.5. I'll give 5, but I'm still giving 5. Every single med's gonna prolong your QT, except Reglan, which is not gonna fix the agitation. But if they're calm, maybe you just start with Reglan.
Try to research on additional dose. To actually affect QT. Like,
I haven't looked at it. Yeah, I think it's theoretical risk. I don't know if it's actually evidence-based.
I never give Haldol IV only because even though a lot of people do it and said they've gotten away with it, but it's not approved for IV use. So if something did go wrong, you might be, and their lawyer was smart enough, they might hang you out to dry.
Give Joe
A lot of
Peridot.
people, Center loves, gives it IV all the time.
You give
but
Joe
I never
Peridot.
give it IV. I only give it IM and PO.
Would all have less effect on the QT.
It's probably similar to SL though. You could give benzos. It's still gonna make them super nauseous. Still gonna be nauseous. Asleep and nauseous. All right. Oh, this is a case study. 35-year-old male presents with dizziness, palpitations after drinking herbal tea containing aconite. What's the rhythm here? Someone said by Gemini. So by Gemini requires you to have a underlying sinus rhythm. Is there underlying sinus rhythm? And usually you get some type of pause after each coupled beat. So this is actually pretty regular, right? The rate, not the QRS complexes. So we can all agree this is tachycardia, right? How is the QRS complex? Let's focus on V2. It's wide, so wide, 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 wide. Someone mentioned alternating. So here you're down in V2, so left bundle, then you're up, right bundle, left bundle, right bundle, left bundle, right bundle. What is this? What's the rhythm here? This is a classic boards question. So this is a ventricular tachycardia. This is bidirectional ventricular tachycardia, which is associated with what type of tox? Digoxin digitalis, which I guess is in this T.
It's one of the like H-like substances and cause H. It actually responds to H.
Yeah, so it's antibody.
What is that?
It has a digitalis, a glycoside inside. It's some kind of flower or reed. I've never seen it from Acolyte. I've never seen anyone drink aconite, but I did have a case at Lincoln many years ago where people made a tea out of lily of the valley. And that has a digitalis glycoside in it. They came in where the mostly runs of VTAC. And we use digibind on them.
Still waiting for my first Digitox case. It's been 10 years. We'll see. People are still getting digoxin. Yeah. Because I've seen some of our attendings get the digoxin, so we're still getting some again. It's good for, I guess, for rate control, not rate control, like outpatient rate control in someone with heart failure. Yeah, so you need good outpatient follow-up. All right. This one's easy. I hope this one's easy. If I taught you anything this year.
Oh, maybe that's hope.
Obs, right? This patient comes with crushing chest pain. What's the diagnosis here? Rule out PE? Nah. So this is a classic. What type of MI? Inferior. What's the rhythm here? But just look here.
Looks like in like last memo.
It's dissociated.
Yeah, so
These they're distant, but they're not.
so there's a PV for every QRS, but if you notice the PR intervals are all changing. They're probably dissociated almost at a similar rate. So here it's super long, and then here it's like really long here, and then short here. If you march them out, looks like there's AV dissociation. So this is complete heart block, which you can see. You see AV. I think it's applied by the right coronary. So you can get AV dissociation and inferior MIs. Just gonna make your heart palpitate. See.
And besides the inferior wall MI here, which obviously this is, and there's AV dissociation, so if they're bradycardic and hypotensive, you might actually try atropine. Sometimes it may work, but actually you may need a pacer or an epi drip and then a pacer. But the other thing to worry about here, if they became hypotensive, was the elevation in F. I'm sorry, the elevation in 3 is higher than that in 2.
So yeah,
Right? So you have to worry about what else. There it is.
right-sided MI. So which you can get pretty hypotensive. If I was at county, would I be trying to fiddle around with the right side of EKG? If I wasn't too busy, probably, but here you probably can because you can have activate cath, you have cath here, but you don't want to delay too much. It can be if the patient's hypotensive with an inferior MI, odds are they have a right-sided MI. So you can give boards. No, boards are always going to be a lot behind. So I think there's recent literature looking at giving nitrates in right-sided MIs, and they've had no adverse effects. I've given it in someone who's hypertensive. And they have chest pain. It's probably going to help their chest pain. So we're going to go into a board review question. Patient is 65 over 45. Which of the following is appropriate initial treatment? Fluid bolus, good. You guys are smart. See. So these patients are in boards classically preloaded dependent. You can give liters and liters of fluids. I've seen attending give 6 liters of fluids, but just be aggressive, right? See.
How would you not?
So this is a board question. Sometimes you're doing these simultaneously, right? So this is what's the next best treatment, right? Initial treatment. Epi drips still have to get out of the Omnicell. IV fluids can be hung by residency. All right, so you've given 6 liters of fluids. What did I put here? 6 or 8? 6. Okay. Patient still. You're transcutaneously pacing the patient. What on boards? What is the first line treatment for refractory hypertension in a right-sided MI? Someone said epi. Levo, yeah. So levo, just keep it simple. It's always levo, except in anaphylactic shock. I would probably start both of them. Ideally, I wouldn't be, the patient shouldn't be in the ER that long to be considering having you contemplate which pressor they should be on.
If you have a TVP, would you really have to do epi or intermediate, or you're not really thinking about it?
Don't think about it too much. You're not going to be placing a TVP ideally. I think so you can transcutaneous. So this patient's already heart rate's optimal, right? They're in the 70s. So you know that the hypotension is not from bradycardia. It's from their massive crushing MI. You had a question? This is an over exaggeration. I guess you got to do it based on clinical scenario. You feel like the patient can take more volume, then sure you can go up to 6. But so yeah, definitely can go in pulmonary edema, but it's the right ventricle that's down. So that fluid might not even get into the lungs, right? They're having problems with forward flow.
The other thing with that case is that once you've given enough fluid and they're still not responding and they're still hypotensive and you give them the noepi and it comes up, but they look like they're in failure, you could then add dobutamine to that. You don't want to do dobutamine when they're very hypotensive by itself, because that can cause vasodilatation and can lead to more hypotension as well as arrhythmias.
All right. Sorry, there's some overlap with board review, but so post-cath, you're in the CCU, patient suddenly short of breath, and we got, this harsh blowing holosystolic murmur that you can hear in the quiet of CCU. So I sound like government. I wrote this a few years ago. So what is a likely etiology? Hey, papillary muscle rupture. And I did look this up, Caleb. Most of the papillary muscle is actually perfused by the RCA. So that's what open evidence told me. Yeah, it must be right. I didn't fact check it, but I got 90% on step 1, so it's got to be good. See. All right, next one. 70-year-old female presents with med refill. What's the rhythm here? Fast discharge. Is this a sinus rhythm? I don't think so either. What's the rate here? It's probably close to. Yeah, it's 150. What should you be thinking?
Like a flutter rate.
Atrial flutter. Do you see any signs of atrial flutter other than the rate? So here, I see sawtooth pattern, right? So this P wave, this flutter wave's in the QRS, and then you have the flutter wave here. They kind of march out at a rate of 300 atrial flutter.
When you have a very regular rhythm with a narrow complex at a rate of around 150, 140, your differential is going to be, atrial flutter with 2-to-1 block versus sinus tap versus sometimes what we used to call PSVT or AVRNT, whatever you want to call it. But those three rhythms, and you have to figure out which one of those are because they have different treatments, right? The sinus tap, you're going to treat the underlying cause. If it's PSVT, what we used to call PSVT, then it probably is going to respond to adenosine. And if it's 2-to-1 flutter, you're going to either shock them or you're going to use something that blocks the AV node, like the calcium channel blocker or like the thiazem or a beta blocker. So it's important when you see a 150 rhythm to the tachycardia in an adult to decide what you think the underlying rhythm is. That does make a clinical difference for your treatment.
You can use the medicine to kind of uncover the.
Yeah, you can use adenosine. You could. I'd probably just use some AV nodal blocker. You're gonna give an AV nodal blocker anyways.
Yeah, and if you gave adenosine, it would slow it, you would see flutter, and then 10 seconds later, it would go back to a fast rate. It won't treat it, it'll diagnose. Or if you're brave like me and you give carotid massage, you'll see it slow down and you'll see the flutter waves. When you take your finger off, it'll go right back to a fast rhythm and you've made your diagnosis.
I think Catherine,
Someone may yell at you for using carotid massage.
we had one in CCT the other day and broke with adenosine, went back, and then getting labs on the patient. Patient was holding their breath and they converted out. Yeah. All right. 32-year-old male, history of depression, headaches, presents with intentional ingestion. Terminal R, yeah, this one's a terminal R. So what's the tox? TCA, yeah. So RS ratio greater than 0.7, wide QRS, right axis, prolonged QT, which you can still see, sinus tach. These are all signs of sodium channel blockade. 71-year-old female presents with shortness of breath, recent knee replacement. So right axis down in one, actually almost also down, maybe yeah, up in VVF. Right bundle here. So you see a wide QRS with a upright R and V1 and V2 and this rabbit ear type thing. Someone mentioned S1, Q3, T3. So what are you guys what are you thinking? Yeah, so this is signs of right heart strain, right, which could indicate a pulmonary embolicity. All right. So back to boards. So you're getting TPA, patient is hypotensive. What is the initial treatment for hypotension in a massive PE on boards? Or in life? A 2-liter bolus? What happens if you give too much fluids in a massive PE? Yeah, so you're dilating the RV, which pushes into the LV, which drops your cardiac output. Yeah. Phenylephrine? No. Nah. Remember, it's always Levophed, right? Yeah. Yeah. I try to put the vasopressin to mix, get you guys confused. Yeah. Yeah, Norepinephrine. I think vasopressin actually doesn't affect the pulmonary vascular so much, so might be helpful in RV strain too.
Definitely don't want to use phenylephrine. It'll increase vasoconstriction in the pulmonary vasculature.
Yeah, and you'll increase your R strain. What's Only to replace someone's milrinone that they're already on at downstate. I think you can off-label use it as a pulmonary dilator. You can nebulize it, but it's easier to nebulize nitroglycerins. It's easier to get in the ER. So what's the treatment here? Mag, what's the diagnosis? Hersats, yeah. I don't have to go into this. Look where to start. What is this? What's the K? Let's do this. Well, yeah. So what are the findings of hyperkalemia here? And what's causing the hyperkalemia? Based on this clinical scenario. Urinary retention, good. So here you also see, you kind of see borderline right axis, actually almost a AVR elevation, but it looks really weird, right? The QRS is wide. If you really look down here, the PR is pretty long. You can see some P waves, and this is concerning for hyperkalemia. So put a Foley and give some calcium and insulin. Do you guys know how? So that whole bundle, the albuterol, insulin, D50, what else do we give? Maybe some sodium bicarb. That doesn't help. How much does that drop your K? It's about 1.0. I think at either at maybe 1 or 2 hours. So you always got to consider redosing all these meds. Sometimes, we used to have a lot of these patients in county with misdialysis. I don't see it that often. I know you guys think we do, but a lot of times we would, give the treatment, admit the patient. There's that period where there's no one taking care of the patient, and they can go back into hyperkalemia. This one's a real case. 50-year-old with ripping chest pain, rain to the back, drinks 8 to 10 energy drinks per day. There's not a resident here. This is a sign out to me. What do you guys think?
What is that? That's not global ischemia per se.
AVR.
What do you think about the size of the QRS?
Yeah, pretty high voltage, right? So you have pretty tall R waves in the leads that are on the left. So kind of even in the inferior leads and the precordial leads, where you see
That's LVH with strain and that's a risk factor for what? Of ripping chest pain.
what did you guys say? Dissection, good. So this actually was a code art, and then while they're just fiddling around with the focus, they saw a dissection flap. So even when we miss, we hit. It's good. See. Yeah. So wherever how I like to think about, although this is a little bit abnormal, whenever you have tall R waves, you will have depth depression. In versions where you have deep S waves, you have S elevations. Yeah. So I mean, here typically you should have the tallest elevations or depressions in the tallest leads. Here it's actually kind of a little bit out of proportion compared to these two. But this could be either from uncontrolled hypertension, or maybe he's having global ischemia from aortic dissection. So, board review question: blood pressure is 230 over 140, heart rate is 115. Your med student hears a murmur. Which murmur do they hear? Same patient. C, decrescending, crescendo, high pitch blowing, diastolic murmur at the left sternal border. What's the aortic regurgitation? So apex, I always think mitral, and then this one's for me, it's always kind of easy to remember. The harsh crescendo, decrescendo is aortic stenosis. All right, so as you're trying to get this patient, so that's a sign of type A, right? It's affecting the valve, so that's type A dissection. You're trying to get this patient to the OR, but their vitals are still kind of crazy. What's the next best step? E, good. So ESMO, which is you always add a load first. All right. It's I think 500 mics per kg, 50,000 max. All right, this is our last EKG. 30-year-old EM resident presents with forehead lack after syncope times 2. So right bundle maybe. That's actually so. Whoop, yeah. Is there a S1Q3T3 here? Maybe. A little Q, yeah. So maybe early repole, Brigada, complete right bundle. I don't know, pretty non-diagnostic EKG. Would you say this patient showed up to shift? Would you send them home? They gotta work. Get your ass back to work. This was me. Not a funny story, but I was second year resident, enjoying my sick call. Got called in the night before. Happened to syncopize in the middle of the night after I went to the bathroom. Saw the cut, tried to wash it, but I didn't have hot water at the time, so I just passed out again. And then I showed up. I called put him in my group chat. Hey, I need someone to fix a lack for my shift, and everyone was already drunk. It was like a Friday night. So I got one person to fix it. No anesthetic, but show up to work. Program director goes, "What were you drinking last night?" I swear to God, I only had one beer. And they got an EKG and told me to go back to work. But yeah, fun times. But it wasn't Dr. Wills. All right, that's yeah. Nah.
I remember.
All right, you guys got any questions? Cool. All right, enjoy procedure day. See.